Well, it's been a pleasure working in the brain tumor community. It's actually very small, so throughout the world, we all know each other. We all go to the same few meetings. We're all talking about the same illnesses. Does anyone else have any idea? And every meeting I try to sit with Helen and Kerry. And a lot of it is because they're fun. A lot of it is because we have good stimulating conversations. So I mentioned one of the huge needs that we need is more clinical trials. And that needs to be supported. So Helen's going to educate us about the types of trials and how do we access them and things like that, because a lot of the patients that I see, they're constantly emailing me, what about this trial? What about that trial? And that's how I think both of us learn. Helen?
Well, thank you for asking me to talk today, guys. I started my career very much like James, maybe a little older, but I won't fess up to that, as a general medical oncologist. And in our unit of 3 at the time, we did lung cancer, breast cancer, colon cancer, and we had clinical trials going forever. So when we started to branch out into brain tumour trials, one of the first things I did, which was a huge mistake, was a story like James got from the Avastin, and we did a trial with thalidomide back in '98. It was a disaster. It worked in a couple of patients. It was very frustrating. The company that said they'd pay for the drug came through at the last minute and didn't. And I managed to convince the boss at the time that he should supply it, and it only cost him $30,000, and 100 later, I was almost sacked. But we went through that, and that was at the beginning of '98, and there's still a patient with a recurrent GBM alive and well today from that trial, which is a small success and a lot of effort. So just starting, why do we bother doing clinical trials? And that is really to test the safety and efficacy of a new medicine or therapy to treat a particular human disease or condition. It can be done with anything. It can be done with radiation. There's some stuff about hypothermia at the moment, microwave treatment, surgical treatment, drug treatment, or combinations of drug treatments. And I think as we hear about these fringe benefit medications such as hypothermia and microwave treatment, it's about time they stood up to the mark and told us how many treatments they'd done and how many patients it worked for, rather than going on to the internet and claiming that it's a good thing to do. So I'm all behind clinical trials. And up until about 12 months ago, for glioma, we had a trial in almost every disease. We now are down to 2 trials, and it's very frustrating that we can't get more things off the ground. How is a trial initially developed? It can be developed by a local investigator, like James pressing for Avastin. It can be developed by cooperative groups such as Cogno, and they're called investigator-initiated studies, or we can be encouraged to join into large pharmaceutical company-sponsored trials. There's an enormous process that we have to go through in Australia to get a trial up and running at a particular institution. We need to set up a trial protocol and put it to various committees. It needs to outline why are we doing the study, who will and won't be included, how many people in total are going to be included, and what study endpoints. What are you trying to answer? What question are you asking, and what are you expecting to achieve by participating in such a trial? There is enormous safety monitoring. Anyone that sneezes or goes to an ER room has to be evaluated and reported to the TGA in Canberra as an adverse event. Once all those regs are actually passed, you might get your trial up. It's presented to an independent ethics committee consisting of physicians, scientists and consumers who have very strict criteria for saying yay or nay. They have the power to approve, reject, or ask for further explanations or modifications. And also, if it's not a registered drug in Australia, it has to get a federal government approval as well. And all that can take, depending on how your ethics committee is feeling at the time, up to 6 to 9 months. If you've got a good ethics committee, it could be through in about 6 weeks. Trials can only be run at a centre that has all the local government and local tick-offs. Eligible patients will be asked by their doctors if they want to participate in the trial. They then must sign an informed consent before any tests can actually be done on these patients to say whether they're eligible or not. Any data that we collect is de-identified, so we don't send John Percy Smith's data to Switzerland for evaluation. They're given just a trial number to maintain patient confidentiality. And these trials involve a team of doctors, pathologists and radiologists. Clinical trials nurses are essential to run a proper clinical trial. If I'm not backed up by this fantastic team of clinical trial nurses, it just won't happen. You need a collaborative pharmacist who doesn't take 10 hours to mix up a dose of selengitide, which they can if they're having a bad day. And you have to be responsible for organising and recording every bit of data on anyone that comes through. And you know, in one of the trials that we were involved in, we have these 5 foolscap folders bursting with information, and every page and every box has to be ticked. So the patient might spend 5 or 10 minutes getting reviewed, and then the trials nurse will go back to her office and tick off all the pages, upload the data into an electronic form, send it overseas, come back and review any queries that are presented. And this can come months and months and months after the trial's completed. And we were involved in a trial recently, and all the trials folders have been sent to India for ever and ever, and they want a trial query back on one of those data files. So we have to get that original thing back from India and answer their query. We've complained. But, an adverse event, an unexpected complication occurs when someone's participating in a trial. It has to be reported back to absolutely everybody, preferably legally within 24 hours of it occurring. And the regulating bodies have the trial to suspend a trial, cancel a trial, if they think that these things are coming on a regular basis and patients are being put at undue risk. And the regulating bodies can turn up on our doorstep any time of the day or night and do an audit to make sure that what we call source documentation is the same as what you've entered onto the CRF, which has been uploaded onto the international database. And if you don't pass the audit, you're suspended. Big smack on hand, maybe your license is suspended, and things can just go into the never never. How are clinical trials funded? I'm pretty over hearing from people that it is the big pharma trying to make money out of the poor patients for their own financial benefits that we try and sell and flog drugs to patients. And I hear that time and time and again. I'm not sure where it's all coming from, but the cost of doing these proper trials is enormous. We have to fund all the salaries, the investigations, the MRIs, the blood tests, and the audits, and it usually needs to be covered by independent funding. Some small local trials can get funded by research grants or patient donations to research bodies. Pharmaceutical company trials are funded by the industry. Australia was actually considered a really good place to be doing clinical trials. The quality of data, the quality of medicine is fantastic here, and then the GFC hit. So instead of $1 being, 50 cents will buy you $1 now $1.03 will buy you $1, and we've become very expensive. So we are not attracting trials like we used to. There are 4 different kinds of trials. The first, as has been mentioned, is something called phase 1, and that's when you first administer a new medicine to a human being. These are extensively tested on animals, and then it's finally introduced into human studies. Humans have a unique metabolism, and this was brought home by the thalidomide. The only animal that metabolizes thalidomide to cause phocomelia, which is the birth deficits in unborn babies, is a white New Zealand rabbit. So all the tests in 1960s were done on rats, and rats don't have a problem with the embryogenesis because they don't actually produce the same metabolite that causes the problem in humans. So even though we've gone through all this animal testing, it doesn't mean when we introduce it into the clinic, it's necessarily going to be safe. So these phase 1 tests have to be done very carefully. And if we miss it, it can lead to dreadful problems. The aims of phase 1 are to really tell us how to best administer it. Is it okay to give a pill, an IV injection, an IV infusion every 2 weeks, every 1 week, every day? What side effects does it cause? What is a safe dose to take on to further testing? And do we have a surrogate marker? So say we've got one of these very specific targeted treatments. Is there a blood test we can do to say in your blood cells, even though we're trying to treat a brain tumour, that we're actually hitting that target and knocking it out? So forever we're looking at a surrogate marker in these phase 1 trials as well, because we might actually reach an enormous dose on a phase 1 trial, but we only needed 25% to knock out the target, and therefore why give 5 times as much? The drug in a phase 1 is usually administered to a cohort of 3 patients. So you choose 3 patients. They're usually any kind of progressive cancer. They are very carefully monitored. Blood levels are taken, either 5 times a day or daily. Any side effects on liver, kidney, immune function have to be documented. And once those first 3 patients have gone through a length of time to say that they haven't fallen off the cart and we haven't caused any major side effects, they'll then choose their next cohort of 3 patients to take on board and up the dose. So if you're lining up to try and get onto a phase 1 trial, which I've just noticed recently trying to get some patients onto phase 1 trials, is that I can't ring up and say, can you evaluate my patient? They go, we've just finished level 2. We don't know if we're going to take more onto level 2. We don't know when we're going to do the final evaluation on level 2. You may be sitting around till May or June before we decide to take the next cohort of patients on. So phase 1 is very unsatisfactory from a patient point of view because you don't know which day you might get a phone call. And usually with a high-grade glioma, you can't wait around for that call. So we then eventually from phase 1 want to know what is a safe dose, is it hitting potentially the target, and what side effects could we expect to see if we took that dose into clinic. So the next stage it goes through is a phase 2. This is a trial when you select a whole lot of patients suffering from exactly the same disease, obviously in our group relapse glioma, and you test those patients. Does it appear to work, and is it safe in those particular patients? If the results of that usually can involve anything from 30 to 200 patients, depending on what difference you expect to see, any side effects you may be running into. And if it looks promising in phase 2, then it goes to phase 3, which David and I have a problem with, but it needs to get done. So the results of phase 2 look really good when you're comparing them to a group of historical control patients. Now, if you ask me when I started in glioma, and I won't tell you how many years ago, the median survival for someone with a high-grade glioma was 6 to 9 months. It is much, much, much different than that now. People, as you've heard of, are living 5, 10, 15 years. So if you've selected your really good group of patients into your phase 2 and say a team of Olympic rowers versus, the 75-year-old grandmas with diabetes, your phase 2 is going to look spectacular and you're going to go, hey, I've got a new treatment for you guys. When in reality, those Olympic rowers were going to do real well anyway, no matter what you threw at them. So it is very important that we try and not just take historical controls, and that needs to take into account that radiotherapy is getting better, surgery is getting better, supportive care is getting better. So you can move a curve just because you're going to a unit that takes care of your dexamethasone, your depression, your DVTs and your diabetes versus not. In phase 3, these things are compared head-to-head with the best available treatment. So if you're in a phase 3 trial, you are not just getting a sugar pill. You are getting the very best available treatment there is, plus maybe something or placebo. So you're not missing out. You're just maybe not on the real thing. And we will never get a trial through ethics that doesn't offer the best available treatment to patients in a phase 3 setting. It just simply wouldn't be approved, and you wouldn't find an investigator anywhere that would actually take it on. So the end point of a phase 3 is, does the new therapy have a better outcome than standard treatment? Are there a lot more side effects with the new treatment versus the standard treatment? What's the cost of the new treatment? And that is not only financial. It's a cost directly to patient care and quality of life. We've been involved in a trial called Centric. Patients had to line up at the hospital twice a week for their entire life having an IV infusion. Now, that's a pretty big cost to a patient's quality of life. So if you're going to increase the side effects, you're going to make them spend more time in bed, you're going to take 2 days a week out of their life by spending more time in clinic, but you're making them survive for an extra 3 months, that has to be taken into consideration, and it may well not be for everybody. The outcome of phase 3 in Australia is then presented by the drug company normally to the TGA. There are 2 main regulatory bodies in Australia. There's the TGA, and they look at the safety and efficacy of any new treatment and decide whether the Australian government should give it the tick of approval for an indication. If they get the tick of approval, it is then set up to a body called the Pharmaceutical Benefit Scheme, and they look at the cost of this new treatment in economic alone terms. How many months of life do we buy by spending $30,000 a month giving somebody this new drug? There is an increasing tendency in Australia for the government not to fund new medications. It often will get accepted by the TGA and not the PBS funding body. And there's one example down here of a new vaccine therapy for melanoma, which costs $120,000 for 4 doses. Even with metastatic disease, it actually cures a few patients. But on the other hand, there's no way known to man that unless you have some kind of very rich uncle, that you're going to be able to afford to get anywhere near it. Now I'm going to use bevacizumab or Avastin, which you probably know. I'll stick with Avastin, and where it started, just as an example of where do clinical trials go from. And I'll apologise to James because I didn't know you were doing this stuff at Duke, so my historical control is not quite so good. From first in man, when we first started giving Avastin to humans, it was about 1998 when they gave it to patients with all kinds of disease. And the first thing we heard of was a guy with a hepatoma who had an undiagnosed brain met that hemorrhaged. And David Suresh went ballistic, and we all thought never for brain patients. And it took people like James to change their mind. This guy is one of my heroes, and I actually tried to get him to dance to ABBA at a meeting in 1998. There was about 200 people at that stage that were interested in anti-angiogenic therapy. He actually published an article in 1971 in the New England Journal, very prestigious, saying that all cancers were dependent on the formation of new blood vessels, and if a tumour could be prevented from growing new blood vessels, it would wither up and die. And at that stage, even though he was a professor at Harvard University, he was poo-pooed and disregarded by most of his colleagues. Then, despite his initial rejection, some of us are a bit stubborn, he persisted with his work, and there are now over 50 blood vessel blocking drugs available for clinical trials, and some of them have actually gone into clinic. The major blood vessel growth factor that we've identified in high-grade glioma is VEGF, and a company called Genentech, which is now partly owned by Roche, developed an antibody that binds this circulating growth factor up. The first studies, as I said, began in the late 1990s, and it was first registered for the management of colon cancer, and it's been tried in breast cancer, ovarian cancer, lung cancer, renal cell cancer, you name it, because this blood vessel phenomenon is common to most cancers, including myeloma and potentially leukemia, which doesn't make sense. In 2005, this is the first you didn't publish your 2002 work. I heard that there was a very enthusiastic oncologist that was working at MD Anderson, and she was confronted by a young female physician who was suffering from a recurrent brain tumour, who brought the research in and said VEGF is very important in glioma, and irinotecan works in a few patients, and I want this therapy now. It took a while to get it convinced, and most of the MD Anderson fell off the floor because they'd never seen responses like it. Numerous trials after this initial findings were ensured. James has been leader of a number of them. The phase 2 trials, when we took a whole bunch of patients, gave them either Avastin plus or minus chemo, were all published. And we know from other cancers that if you start treating early rather than treating late, you have much better results. 2 abstracts were presented in 2009 suggesting if we started Avastin the day we started their chemoradiotherapy, we were going to get a much better outcome than if we started it when they recurred. And then 2 phase 3 studies went into planning. One of them, the Avaglio study, where a lot of patients in Australia were put on that study. There's an 8525 study we're waiting for coming out of the States, which is very similar. So Avaglio or Avaglio, depending on what side of the world you come from, took on 921 patients. Why they needed so many, I'm not sure, but I'm not good at stats. And you were basically either giving chemo, radiotherapy, or chemo plus a saline infusion versus chemo, radiotherapy plus Avastin. And as an investigator, none of us knew whether the patient was getting saline or the patient was getting Avastin. And one of my patients who decided to come off trial because he was getting all these side effects from the infusion about 18 months out, then decided to go on another trial. We needed to know if he was had Avastin or not, and he was actually getting side effects from the saline infusion he'd been getting for 18 months. So it was quite interesting what an effect placebo can have. So the first analysis was presented at a meeting in November 2012, and it showed that if you got Avastin from the day you were starting chemoradiotherapy, your progression before the tumour occurred, before it started to cause you trouble, was improved by 4 months. But this early analysis, which is going to be updated in June at a big meeting we're all going to, suggested that your overall survival didn't change. So that was a pretty disappointing result, given the 2 phase 2 studies said we're going to improve overall survival significantly by giving this drug to people from the day of diagnosis. Progression-free survival does have a significance for patients, and there was an average of spending 10 months less on high-dose steroids, and anyone who's been on high-dose steroids that doesn't need to be on high-dose steroids will know what a benefit that makes to quality of life. And the patients receiving Avastin actually enjoyed a better quality of life from 3 to 4 months. We're waiting for the survival numbers to come up, and then we're going to have the problem with the Australian TGA PBS, who will pay for it, will they pay for it, and what battles do we have to go through. Some other promising drugs that looked very good in phase 2. There was a drug called selengitide, a drug called enzastorin, and a drug called cedaranib. All looked like they were the big breakthroughs, went into phase 3 and flopped. And at the moment, the mood amongst drug companies supporting brain tumour trials and the mood amongst investigators that have been involved in these trials is pretty disappointing, because, I mean, you put a lot of effort into doing all this stuff only to find out that you've tortured people for so many months and it hasn't been what the outcome you really wanted. We're pending some results from a study that looked at people with low-grade tumours. Often people with low-grade tumours have resection and are observed at the time when they need to have therapy. This trial looked at 12 months of pills versus radiotherapy, and I've heard a rumour that that is going to come out in June at ASCO. With some interesting results. We were just involved in a trial with a drug that inhibits another growth factor along the pathway called TGF-beta. That trial is now closed, and we'll have to wait the results for that. So in Australia, as far as I'm aware, we're pretty, from nearly anyone that walked through my door being shoved on a clinical trial to now, I don't have anything to offer them. I don't have much at all. There's the EITC Catnon study, which is looking at undeleted grade 3 tumours, and we're trying to work out, is radiotherapy alone okay, or should we give them extra chemotherapy along the way? What's going to be the best outcome for that? There's the ACT4 study that David mentioned, the Celldex trial. We send tissue off after diagnosis to find out if you have this particular gene expressed on your cells, and then it's a phase 3, so you get randomized to just getting a nice immune stimulant in the top of your thigh versus an immune stimulant plus the targeted agent against the EGFV3. And there's a study looking at elderly patients because this disease is common in people over 65, and we're finding that patients over 65 do not necessarily tolerate 6 weeks of chemo radiotherapy very well. And studies out of Europe suggest that we may be able to truncate that to 3 or 4 weeks and give them just as long a survival but much better quality of life by not bringing them in and out of clinic for 6 weeks. There's some phase 1 trials going on in Australia. One of them is do nanoparticles work for high-grade glioma? That study is run by a company called Ingenix, which is a local CSIRO offshoot. That's going on in Melbourne. There's an EGF antibody study going on or about to open in Melbourne. And as David's talked about, can we make a decent vaccine against CMV and improve things? So for a patient, I had an email at 4 o'clock this morning from one of my young guys who's really starting to get into a lot of trouble saying, I want to go on to a trial now, and I don't have the heart, or I didn't this morning, to go, matey, I don't have any trial for you. It's very difficult. But as a patient, it's not easy to be on a trial. Both the doctor and the patient and the family need to be committed. Us as physicians have a lot of legal obligations and rules to follow. It adds on hours is not something that we're paid to do. These are free hours added on at the end of a very busy week. I need certainly at our unit to know